how to perform superior surgery on the inferior oblique and avoid inferior surgery on the superior oblique. And first, we're going to talk about surgery on the inferior oblique, superior surgery on the inferior oblique. And I will say at the outset, as you can imagine, there's a lot that would be in this talk that overlapped with the Kaye lecture, the vertical strabismus. So I'm not going to just be repeating slides and so on, but I may have placeholders saying I covered this in the Kaye lecture. So, and the first thing, of course, errors in diagnosis. We're going to talk about unintended surgery, some technical issues, a little more stuff on the anti-elevation syndrome, undercorrections, overcorrections, and what may be a new term for you, something I call an uncorrection. So the errors in diagnosis, over elevation, I'm not going to go over this in detail. This was covered in the Kaye lecture and it's all there, but I'm just putting this in for the sake of completion. Unintended inferior oblique surgery, that's where you wind up operating on it and you don't want to. This is a patient that had undergone a left lateral rectus resection. And you see that there's it doesn't show up very much there, a small left hypo, but look at that on attempted adduction, and there's an X cyclo. And this is what I have labeled the inferior oblique incarceration syndrome, that the inferior oblique is loosely adherent to the lateral rectus via some tenuous attachments, but when you're pulling the lateral rectus forward, if you don't adequately sever those, when you're pulling forward as in a resection, you can drag the inferior oblique forward with it, and it'll scar into the lateral rectus. And actually, in the series of inferior oblique incarcerations I published, it was a little inconsistent what their motility pattern was, not as predictable as the superior oblique incarceration, which we'll talk about later. But I think the majority of them were represented, manifested what's represented in this slide, a hypo and an X cyclo. Here's a patient that had undergone a scleral buckling procedure in the right eye, and he's got a small right hypo, but he can't look up with that eye. And this is also unintended surgery. It's an artist drawing, but the encircling band basically wound up tucking the inferior oblique. So what happened was when the surgeon put a hook, the retinal surgeon, under the inferior rectus, probably came from this direction, hooked the inferior oblique and pulled it forward and then passed the silicone band underneath it and put this bend in the inferior oblique, and you get a restrictive hypotropia, basically being tucked by the buccal. Another example of unintended surgery. Technical problems. Let me just, you can have a bifid insertion, or in this case, a trifid insertion. This is a slide courtesy of great Canadian strabismologist, Stephen Kraft. Here's the inferior oblique. It's an autopsy eye, and you'll see it has three completely separate heads. So when you hook the inferior oblique, if you get the hook between one of these heads, you don't capture the whole muscle. Or if just the way you pass the hook, the technique, even if it's not a bifid insertion, you can miss it. Let me just move this, these photos are on the side. Other technical problems, you get adhesive syndrome, and interestingly, missed muscles due to extortion. We'll talk about that. Incomplete capture of the muscle. Now, if you have an overacting inferior oblique, presumably you have that, or you wouldn't be operating on it in most cases. The eye is X cyclo rotated, And that alters our anatomy. And if the eye is excyclorotated, the lateral rectus muscle will be down closer to the inferior temporal quadrant where the inferior oblique is, and the inferior oblique is closer to where the inferior rectus is. And that can lead to missing hooking the muscle. So I think it's important when you embark on surgery to make note of fundus torsion for many reasons. But number one, in this case, you want to determine if the eye is markedly excyclorotated, because that's going to alter where the muscle is. I recall a patient I saw, and this goes back to the late 70s, was someone fairly new in practice, because when I told the story, you may say, how could someone make a mistake like this? But he was fairly new in practice, and he had a patient with esotropia and inferior oblique overaction, and he recessed the medials and recessed the inferior obliques, or so he thought. And the patient was absolutely unchanged from the surgery, both with respect to the esotropia and the oblique dysfunction. Sent the patient to me, and it turned out that he recessed the medials and then recessed the laterals because the laterals were down in the inferior temporal quadrant. Now, of course, someone with experience would see the fibers are running the wrong way and so on for it to be the inferior oblique, but it really screwed up his orientation. So the presence of torsion is important to help you locate the muscle. When I hook the muscle, the inferior oblique, I like to see this beautiful white, I call this the triangle of happiness, the bare white sclera between the two arms of the hook muscle. And then I look here and I reflect tenons and look on the inner wall of tenons, and I want to be sure I don't see any fibers running the way my cursor arrow is going. That's what happens when you split the muscle. When you hook the muscle, the inferior oblique, it often comes up. This is the edge of the muscle, and then this is fatty connective tissue behind it. And I sort of wriggle the tip of the hook so it's right at that interface between fat and the muscle. And then I cut down on the hook here to make a little buttonhole for the tip to come out. Now, if I'm posterior and I'm popping through in here, that's what martial arts called popping the fat. And you can end up getting an adhesive syndrome. And that's what happened with this child, had undergone inferior oblique surgery and has a hypo, very restricted, limited elevation and very positive force ductions. A couple other technical issues. Bleeding, the vortex vein is right where we're operating. You want to be careful of that. You can damage the lateral rectus muscle. Too much tension on the oblique will cause an iridoplegia. And the lid fissure changes I talked about in the prior lecture with inferior oblique anterior transposition. I like to consciously visualize, make a point of looking for the vortex vein so that I can be sure I'm avoiding it. This is the inferior oblique muscle here, and I've identified the vortex vein here. And here, very often, if we're doing a recession and we're going back about 4 millimeters, 5 millimeters from the lateral rectus insertion, the vortex vein, as seen in this picture, usually enters the sclera right about where you want to be. So you want to really identify it and then consciously avoid it. You hit it, we have nicknamed it the aorta. Here's a patient who underwent inferior oblique surgery, and he ended up with this right lateral rectus paralysis. And the surgeon inadvertently cutting off the inferior oblique damaged and partly cut off the lateral rectus. And again, the presence of an excyclo can increase the risk of that. So I always make a point of, when I'm doing inferior oblique surgery, of specifically identifying the lateral rectus, putting a hook under it. Martial arts used to put a suture under it and use that for traction. I don't do that, but I identify and keep it out of the way. And then I very carefully sever these connective tissue attachments between the inferior oblique and the surrounding tissue. Now, my personal preference for weakening the inferior oblique is usually a recession rather than a myectomy, and I'll talk about the reasons in a bit. And Marshall Parks popularized the recession, but he used to like to suture, I call it suturing in the hole. Here's the inferior oblique still attached to the globe, and he passed the suture in the muscle there. I find that a little more risky than is necessary. We're actually kind of near the macula there. You don't know exactly how much to leave here, wanting to be sure you get a good bite in the muscle. I like to put a hemostat across the muscle and disinsert it. And then with it up kind of in the air off the globe, I put sutures in the cut end of the muscle while it's still attached to the hemostat. I think that that's safer. Anti-elevation syndrome, we talked about in the Kaye lecture, and exaggerated force ductions, also the Kaye lecture. I want to introduce a topic that I tongue-in-cheek called an uncorrection. You know, an overcorrection is when the patient, let's say, was esotropic, and now they're exotropic, and or they're exotropic, and now they're esotropic. An undercorrection, they're ET, and they were still ET. An uncorrection is when you create a problem that wasn't there at all before. And this is an example of an uncorrection, and there's something to learn from him. Here's a boy who was a high astigmat and had bilateral superior oblique palsies, and I did bilateral superior oblique tucks on him. And he comes in for his post-op visit. This was about 6 weeks after, and he said, well, you know, I'm not seeing double and happy with the muscle surgery, but my vision's blurred. Then he says, but I can clear up the right eye if I do this, and I can clear up the left eye if I do this. And then the light went off. Sure, oblique muscle surgery will rotate the axis of astigmatism 5 to 10 degrees. It'll parallel the amount of torsion change you get. If surgery can correct, let's say a superior oblique tuck will correct 10 degrees of torsion, you've rotated the axis, rotated the eye 10 degrees, you've rotated the axis of astigmatism by 10 degrees. So the important point here is to re-refract any astigmat after oblique muscle surgery. I tend to do it about 6 weeks after surgery. That's around the time I might change their glasses anyway, if I wanted to modify their plus or something like that. But where it's really important to keep in mind is that in your non-diplopia-aware patient, let's say your monofixator who had amblyopia, you patched them, now their vision's okay, but they suppress under binocular conditions. Typically, if they're an astigmat, they've got a greater astigmatism in the formerly amblyopic eye. They're not going to complain of blurred vision. So you have to be proactive and think of this and deal with it accordingly. So, excuse me. Moving on, complications over and under corrections. It's important to keep in mind, you know, they talk about, with superior oblique palsy at least, bilateral mass. You look like you have a unilateral superior oblique palsy, you operate for the right hyper, now the left eye appears to have a superior oblique palsy. That's a bilateral mass superior oblique palsy. But as Jim Ellis really thoughtfully fleshed out in an article he wrote, a simple overcorrection will mimic a bilateral masked palsy. So in other words, if I have a right hyper and it's a superior oblique palsy and I weaken the inferior oblique or do whatever I do, if I've just overcorrected that patient and all they have is a right superior oblique palsy, but now I've overcorrected them, I will have a left hyper that will increase in left gaze and on left head tilt, even though all the problems in the right eye. Why is that important? Well, it may be important as far as planning treatment for this new, excuse me, contralateral hypertropia. One thing that can help you sort that out, so we start with the right superior oblique palsy. I operate now, I have a left hyper. You normally, if it's not a bilateral masked, if it's an overcorrection, you won't see X-cyclo in the left eye. And that's a very important way to sort this out. And you may want to undo some of your initial surgery rather than treat a problem in the other eye. And then, of course, there can be bilateral masked palsies, especially if you didn't measure in the oblique fields ahead of time. You may not have picked up the fact that there was a bilateral problem. And then, of course, in the topic of over and under corrections, we can just talk about an undercorrection. You can undercorrect. As I indicated, like recessions rather than myectomies. And it's a bias, and I know people do excellent work with myectomy. I think it usually works. It is quicker. The main reason I like recessions, there are four. If there's an asymmetric need, so in other words, we have bilateral inferior obliques with a hyper and primary, I can more predictably grade the surgery asymmetrically. It's reversible predictably. And I know myectomies can be reversed, but I find that every time I go in on a previously myectomized inferior oblique, it's a crapshoot. I don't know what I'm going to find. The muscle may have stuck down. It may not have stuck down. I may find it in one place. I may find it in another. And then it's a matter of what do you do with it. So I like the idea that I can go in and I can recess it more, or I can undo the recession. I think re-ops are more predictable if I've done a recession for the reasons I just said. And what's very important, especially if I'm dealing with infantile esotropia, is I can do an anterior transposition later if I want to. And if this is a patient that develops DVD down the road and they've had inferior oblique myectomies, I can't predictably do an inferior oblique anterior transposition. Few things that are probably not that widely known. You can, the principle on the superior oblique, there's the Harada Ito. If you just operate on the anterior fibers, you affect torsion, and the posterior fibers, the vertical. You can do the same on the inferior oblique. So let's say you want to correct X-cyclo, but you don't want to weaken the elevating action of the inferior oblique. You can do this procedure, an anterior disinsertion, and this is how I do it. I first pass a suture through the anterior corner at the insertion, through the muscle, and I just whip it around the muscle. There's no suture in the sclera. I just whip it around like a lasso. And then I disinsert the anterior roughly 7/8. And then I tie this suture up to bunch this, to keep this corner from sticking down. So I've disinserted the anterior 7/8 and secured it posteriorly. And I find this will fairly predictably correct about 5 degrees of X-cyclo. So I'm not often doing this by itself, but if I need an adjunct, I need a little more correction than what the rest of my surgery is doing, it's a useful procedure. Similarly, if I want to get vertical correction from inferior oblique weakening, but without affecting torsion, this might be a case for whatever reason there's already in cyclo and I don't want to make it worse. I could disinsert the posterior aspect, 7/8 of the inferior oblique, just do a mirror image of what I did over here, and I'll correct vertical without torsion. Useful procedures. Okay, so we're going to move along and talk about avoiding inferior surgery on the superior oblique. And in the same vein of what we were just talking about, if you want to operate on the superior oblique and just affect torsion and not affect the vertical, and there are various reasons you want to do that, I think the Fell's modification of the Rada-Ito procedure is very useful. Here is the superior rectus is on a hook here. This is the superior oblique tendon with sutures in it. And most people will suture them just at the superior edge of the lateral rectus muscle, about 7 millimeters back. That's a useful procedure for correcting X-cyclo without affecting vertical. We can do partial tenectomies. This mirrors what I just showed on the inferior oblique. If I want to correct vertical without torsion, we do the posterior 7/8 tenectomy. We cut out this roughly 7/8 posterior rectangle of the superior oblique tendon, leave the little slip anteriorly attached. And that's a weak but effective procedure for weakening the vertical action of the superior oblique. If I want to get rid of, if I want to change the torsion of the inferior oblique, superior oblique, we can excise the anterior 7/8, mirror image of what I just did on the left side of the slide. And that'll give about roughly 5 degrees of correction, fairly predictably. Now, a word about the superior oblique frenulum. This has not gotten a lot of attention, and I think it should. It leads to some of our adverse outcomes. The superior oblique is attached to the undersurface of the superior rectus by a thin connective tissue called, it's a frenulum. And here's the superior rectus up on a hook, and here I'm holding the superior oblique tendon as it goes under. And this thin diaphanous tissue here is the frenulum attachment. Here's another depiction of the superior rectus up on a hook, and you can see the superior oblique is, sort of goes up with the superior rectus. It's attached via the frenulum. So I was interested in seeing what happens to the frenulum as you recess or hang back the superior rectus. And I did a study where I detach, these are all patients that I was planning to do the surgery on the superior rectus, superior oblique anyway. Superior rectus is on sutures here. And I just put a suture in the superior oblique just as a guide. And I pull the superior rectus up to the insertion and measure the length of this. There's a reference knot on the suture of the superior oblique. And then I'd let the superior rectus hang back 6, 7, 8, 9 millimeters and see by measuring how much the knot moved on this suture in the superior oblique, how far the superior oblique went back with the superior rectus. And it turns out that it's about 1-to-1, that for every millimeter the superior rectus is hung back, the superior oblique, now it's not disinserted, mind you, this is just the sort of the body of the tendon, moves back with the superior rectus up to about an 8 millimeter recession. And beyond that, if we don't sever the frenulum between the superior oblique and the superior rectus, the superior oblique will keep the superior rectus from going back further. So if I'm doing a superior rectus recession, I don't cut or sever the frenulum unless for some reason I'm doing a very large superior rectus recession, larger than 8. Here's a young woman who had undergone a superior rectus resection. Doctor didn't pay attention to the frenulum. She developed what I call the superior oblique incarceration syndrome. And this is the mirror image of what I talked about with the inferior oblique. So this is what I found at her surgery. Here's the superior rectus, and here's the superior oblique scarred into the superior rectus insertion. See, as you resect the superior rectus, as you drag it forward, you're dragging the superior oblique forward. So this is other example. This is a different patient, but just to show steps in the procedure. Here's superior rectus. This is superior oblique. Superior oblique here, scarred into the superior rectus, and I detached it. And then, of course, it's a matter of where you put it. That's a whole other discussion. But the important point here is that when you're doing a resection of the superior rectus, you want to sever the frenulum and allow the superior oblique to stay back where nature put it. Another thing to keep in mind is when you do temporal transpositions of the vertical rectus muscles, artist drawing of a temporal transposition, the superior oblique can be dragged laterally with the superior rectus unless you've severed the frenulum, and this can cause hypers. So my general guidelines for handling the frenulum, don't separate it for superior rectus recessions, at least standard amounts or even large amounts. Separate it for large resections and transpositions of the superior rectus. And I'm going to cover this in the next couple slides, pay attention to superior oblique disinsertions. And we're going to move on now to weakening the superior oblique. So there's sort of a hierarchy, I think, as far as power of the procedure. And probably the weakest, but appropriate in many cases, is the posterior 7/8 tenectomy, which I showed you a picture of. Next, a just simple disinsertion. Cut it off of the insertion, let it go. Recessions, I put a plus minus because depending how you do them, they may fit in a different location on this hierarchy. Lengthening procedures, either the silicone expander or the Z lengthening tenotomy. And then tenectomies, cutting out a piece, which will often cause a paralysis. And one thing to keep in mind is what do you do if you need an asymmetric effect? So I have bilateral superior oblique overaction, more in one eye than the other. I have a hypo in primary. I want to weaken both, but I want to collapse that hyper. Or I've got more overaction and down and adduction in one eye than in the other, and I want an asymmetric effect. And not all of these lend themselves to titration. Posterior tenectomy doesn't. Disinsertion probably doesn't. Recession, maybe. Lengthening, yes. Tenectomy, probably not. So this is an artist showing just a simple a drawing of a disinsertion on a hangback technique. So here's the superior oblique tendon. It inserted here. They put sutures in it and they just cut it off and let it go. You could call that a disinsertion or a hangback recession. Now, mind you, we haven't raised the superior rectus and we haven't intentionally done anything to the frenulum. But it turns out that in order to do the surgery, of course, we have to hook the superior oblique and pull it out into view. Here's the superior oblique and here's the superior rectus in order to put sutures in it if we're going to, or in order to disinsert it. And the amount we pull this tendon out from under the superior rectus determines how much we're stripping the frenulum without realizing we're doing it. So if we're doing a bilateral procedure and I pull this out more in one eye than the other, just because exposure allows me to do so, this tendon is going to slip to a different point. It'll go further in the eye in which I strip the frenulum more. So you want to take that into account. Superior oblique recessions are tricky. And the Latin American strabismologists, Ciancia, Prieto Diaz, Sosa Diaz, pointed out that if you recess the superior oblique and follow its normal anatomic course, you're suturing it. The new insertion is now anterior to the equator where it used to be posterior. And that'll cause a restriction of depression and abduction. I apologize that it's partly cut off in this slide, but you can see it. This is a patient post a right superior oblique recession, and down and right, this eye is tethered from going down. And that's a very predictable outcome, which in some cases can be symptomatic. There's superior oblique recession. Now, what the Latin Americans suggested is when they do a recession, they said recess it and then put it way posteriorly and suture it back here somewhere. I think they're 7-8 millimeters posterior to the superior rectus insertion, recess it and retroplace it. That will prevent this anti-depression syndrome, but I'm actually not sure that's any different than just annihilating the superior oblique because it's not functioning in its normal manner. Now, a more predictable way to weaken it, especially if you want to do it asymmetrically, is some kind of lengthening procedure. And this is a picture of Ken Wright's silicone expander, which a lot of people do and like, and it can be an effective procedure. There's some technical difficulties with it. Number one, you really have to preserve the intermuscular septum here, nasal to the superior rectus, or there's a good chance of this scarring down to the sclera. And keep in mind, there's a suture at each end of the spacer. So the temporalmost suture is right at the edge of the superior rectus, and that presses it right against the sclera. So if the intermuscular septum is violated, you're going to get an adherence there. I personally prefer the split tendon lengthening procedure. I think it has all the advantages and none of the disadvantages. So here's the superior oblique tendon, nasal, temporal. I'll put the hemostats a distance apart that I want to expand the superior oblique. Split it longitudinally like this with a hook. And then I'll put a suture through this posterior half. And then I'll cut that, tenotomize it, bring the sutures through the temporal end of the anterior half, release the hemostats and tie, and this is what I do. It's a Z tendon lengthening procedure. Now, note in this, the knot, there's one knot, and it's further from the superior rectus, so it's further off the sclera. So the advantages both maintain the normal insertion path, both maintain a normal insertion and the normal superior oblique path. They're both, at least in theory, reversible. You can titrate both of them, but the lengthening procedure, in my mind, has the advantage of a minimal knot and foreign material. It's just the knot. There's no extrusion problem, less infection. I find it easier than the spacer because there's no need to preserve the intermuscular septum. However, in ways it's harder. Working with half a tendon looks great when you're looking at an artist's drawing, but it's a very small slip of tissue and it's easy to cut the tissue with your sutures and the sutures may pull out, but at least you know that at the time of surgery. So that's my my preferred. I think that's, yeah. So in summary, we talked about the inferior oblique, talked about errors in diagnosis, mentioned them here, mentioned them in greater detail in the Kaye lecture. We talked about unintended surgery. Technical issues, keep in mind that torsion will change your landmarks and vortex vein and so on. Talked a little bit about the anti-elevation syndrome, over, under, and uncorrections. And with respect to the superior oblique, we talked about managing the frenulum, different ways of weakening it, and torsional issues. And I'll thank you for your attention on that. We're a little ahead of schedule on this one because, as I said, there was a modest amount of overlap between this talk and the vertical one, but that'll allow us to catch up because we're running a little bit behind, and I'm happy to take questions if anybody has.
Any questions for Dr. Kushner? Dr. Aragutla?
Hello, Dr. Kushner. That was again
Hi.
very exciting. And I have a couple comments and questions. One of the things that I do when I'm doing any of the oblique, in fact, any strabismus surgery for the benefit of the residents, I always mark the limbus, the muscles that I'm planning to do. So if I'm doing inferior oblique, and let's say, so I'll mark the inferior rectus at the limbus, 6 o'clock position, and the lateral rectus at the 3 or 9 o'clock position. So our orientation remains when we're operating on that. One of the instruments that I train in Toronto at Sick Kids, David Smith, he had designed an instrument called the Smith Dacamara retractor. It's like 2 Jameson hooks on one handle, and that works really well for the exposure of the inferior oblique, like when you mentioned suture in a hole, kind of, it's a very tiny space, and it's so far back. The cornea is totally rotated. You can't even see the limbus sometimes, so far back. That Smith Dacamara hook is actually a very useful tool for that. 2 questions that I had was,
May I, before the questions, I just want to comment and ask you a question. First of all, I'm not only familiar with the hook, but he sent me one. And I've used it ever since it was either, I don't know if he sent it or Steve Kraft sent it to me, but at any rate, that was on my surgical tray. And I agree with you, it's a wonderful instrument. But I'd like to ask you, when you said at the start of the case, you marked the muscle, so before you make an incision, what do you use as your landmark to tell where let's say the eye's extort and the lateral might be low. Do you like grab it through the conjunctiva and then mark opposite it? I'm curious how you do that.
Just after I do my forced actions, I mark it at the limbus. It's not the muscle, it's the orientation.
You mark the
orientation
12 o'clock or 9 o'clock position,
right.
or 6 and 12 o'clock.
Right.
Oh, I'm sorry. 3 and 9 o'clock.
Right.
Okay.
Yeah.
Okay.
And then we sort of rotate the eyeball, and then to approach the inferior oblique, you rotate so much, you now kind of, all you can see is those tips of those markers at the limbus, the pupil, everything's kind of rotated.
Yeah, that's
The
good.
globe is rotated.
Your questions.
Question 1, there's a group in Europe that talk about like the Fink's point and Shay's point for suturing when you do graded inferior oblique recessions. Do you follow any of those schools of thought? And the second is, have you ever done adjustables on inferior oblique muscle to grade the recession?
Yeah, I've done, I'll take the questions in reverse order. I never did a lot of adjustables on the inferior oblique, but it's doable. I'm not sure I have a good solid reason why I didn't do it. First of all, many patients, it is self-adjusted, and I don't need to do adjustable on it. I can't remember off the top of my head what the circumstance, they were special. Usually I do adults rectus surgery, I do adjustable sutures. That's my routine. I needed a special reason to do it on the inferior oblique, but yes, it's doable. Now, with respect to the point, this for those, I presume everybody knows, maybe not. She's talking about what point you suture the recession to. And when I was a resident, Parks was popularizing just going back 3 millimeters and back 3 and 2 millimeters laterally. And that was, I don't know if he called it Parks' point, but that's what everybody did. That was a standard recession. And Parks said that it was, he thought that it was the same as what had been described as Fink's point. And Fink had done a lot of work on, he actually wrote a book on just oblique muscles. And he had a device, it was kind of like a 3-pronged hook. There were 3 points to it, a handle with 3 points. I never used it. I just read about it, heard about it. I think you'd put 1 point on the corner of the inferior corner of the lateral rectus insertion, 1 on the nasal corner of the inferior rectus insertion, and the 3rd point, wherever that touched down, that was Fink's point. And he'd say, that's where you should put the recession. And Parks always said, going back 3 and 2 over is the same as Fink's point. Then there was a study done by Leonard Abt, long time ago, where he took autopsy eyes and he measured, he wanted to determine number 1, where was Fink's point as far as the actual course of the inferior oblique, where was Park's point, and where you would put the muscle if you wanted to do a 6, 7, 8, 9, 10 millimeter recession. And his landmarks were somewhat different. I think, he said the Park's point was not exactly following the anatomic course, and it was close to I think an 8 millimeter recession or a 10 millimeter recession. Parks used to call it an 8 millimeter recession. But Abt he had a table. He said, for a 12 millimeter, you go back 4 and over a half. I think I actually would do these odd numbers infrequently enough that I actually had a printout of the table in my box of loops. And I would, if I wanted to do, let's say, an 8 and a 12, I'd always pull it out, and because it may have been a year since I had to consult it. But I, for many years since that article came out, relied on the numbers in Abt's article, because the only one that was really based on a scientific study. Many people say it may not matter that much. There's a lot of forgiveness in the inferior oblique, and especially if you do the same in both eyes.